Greetings, everyone. This is Eric Glazer, and welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode, we bring leaders in the industry together to not only inform you, but also unearth bright spots, successes at health plans, hospitals, and other healthcare-related organizations around the country. Our goal is to identify as many bright spots as possible so that you can determine the ideas shared on this show can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. The title of today's episode is How Healthfirst is Partnering with a Health System to Make Providers' Jobs Easier. And our guests today, both in the New York City area, are Sami Boshut. He is the Chief Information Officer at MediSys Health Network, and G.T. Sweeney, the Chief Information Officer at Healthfirst in New York City. Welcome to the show, both of you. I'm excited to have this payer-provider conversation. I have divided our conversation into 4 segments. I think we're going to start with design and planning and how you implement new systems that providers actually work within and implement, because so many times we miss the mark there when we think about provider workflow. And we're going to talk about implementation so the audience gets an understanding of how you think about implementing. We'll then talk about impact and the impact everything that you're doing together is having on all the key stakeholders. And finally, we're going to end things and allow our audience to hear a little bit of a blueprint from the two of you on how Healthfirst is utilizing this approach to make your business better and to make life better for all of the New York folks you serve. So I'm excited to hear about all of this. We've done some prep, folks. This is going to be a really enlightening, great conversation. So excited to have it. So, Sami, we'll start with you. I want to talk about provider-centered design. And so first, for the audience, can you talk a little bit about what is human-centric design and how does it work when you're planning for new systems and processes for providers? And then maybe talk a little bit about the keys to success.
Hi, Erica. Thank you for having me today. And absolutely, that's a great start. When we work with our provider, we always wanted to make sure that we provide them the best workflow we can give them. And by thinking about the best workflow, we're thinking about centralized everything in one place for them. With the recent system and all the integration happening in the market in the past many years, providers have to jump between different applications and between different places to get the information they need. So we start by actually talking to the provider, understand their pinpoint, capture that, and then start to work closely with them on how can we centralize their work in one area. So we wanted to make it easier to them to address their patient needs on the real time. We wanted to eliminate the need of multiple systems, Excel sheets, and we wanted to deliver actionable data to them directly into their workflow. So that was, or that is the focus when we're talking about human-centered design.
Sami, can you talk a little bit about, you mentioned you get the providers involved. Can you talk a little bit about how you do that? Is that through a specific focus group? Do you get a provider committee that represents your providers? How do they get involved here?
Absolutely. So it's basically a provider committee. We look at the some of the leadership in our provider clinics and our clinics, and we get the providers, and then we also get the some of our residents that involve in everyday action with our patient. We sit in the committee and we start to talk about, hey, how can we make your life easier? How can we make sure you have what you need to do a better patient care? So transparency is very important. Understand and listening to our provider and discuss those topics with them. It's the key to make this project a success project.
And are they involved in the very beginning to scope it out, or are you having them involved throughout? Like, are you doing sort of UAT for those user acceptance testing with the providers all the way through the process?
Providers start from day one when we start to even think about the idea, all the way out to implementation, testing, going live, post to go live, follow up, and we always tweak as we go based on their needs.
Great. Well, let's talk about implementation a little bit more. And I want to introduce everyone again to GT Sweeney. He's the Chief Information Officer at Healthfirst, so the health plan side of this. So GT, how do you think about implementation? What are the key areas that you need to include to ensure implementation of any new technology, system, or process is successful once you get sort of the provider buy-in, almost that provider almost co-development?
Yeah, Eric, thanks. And thanks for having us today to tell our story. When I think about implementation, first of all, I think, Sami is a leader within his organization, and I would argue within the industry with regard to this commitment to delivering human-centered design to clinicians. And so I think it's incumbent upon the entire healthcare industry, the entire health tech industry to support that vision. So what does that mean to us? It means that I've got to deliver flexible endpoints that can be integrated into whatever business process Sami wants. I need to build it in a way. We talk about composable capabilities. We use the Lego block kind of metaphor for all of this. So we build these Lego blocks that can be assembled and integrated into Sami's workflow. And then as we talk with other parts of the delivery system, we will assemble those same building blocks in slightly different ways to meet the unique starting point and the unique desires and needs of other clinical constituents within Sami's organization or other clinical teams in other parts of the healthcare ecosystem.
So could you take me a little bit more into the weeds and how do you approach this and how does this impact, let's say, the personnel on the health plan side of things as well? Like, I want our audience to understand a little bit of sort of the blocking and tackling. If there's
So health plans have teams that are entirely focused on maximizing quality outcomes and maximizing quality metrics. If you think about Medicare Advantage plans, we're a 250,000 member Medicare Advantage plan in this one market, New York City, and the surrounding areas. So there's a significant quality team, and historically, that quality team has generated really valuable insights. And how did we distribute those insights? We distributed them with spreadsheets or email attachments or SFTP sites, and you can imagine what it takes to get those into a physician workflow in a clinical setting with a patient. It really is hard to imagine how that could happen. If it does happen, the data is pretty outdated by the time, there's a high risk that it's outdated by the time it gets there. And so how do we bring this to life? So the health plan understands these objectives and has these insights, and we've got the legacy ways of distributing them. But what's different here is working with Sami and Sami's team, we found a way to put these directly into the physician workflows. And specifically, how do we engage that clinical team on the delivery system side? The idea of human-centered design is you don't build anything until you test it with the actual users. So in this case, we went through 9 iterations of design with Dr. Tulo and his team at MediSys to get to the right place. And I'll give you an example. Like when we showed gaps in care, we thought the physicians would only want to see the open gaps in care. Turns out they want to see the closed gaps in care, and they want to see some information about when those gaps were closed and where they were closed. Because if a care gap is closed and the physician knows that and didn't already know that in the patient profile, they want to know where to go to get the next level of detail around that. Sometimes we'll be able to give that to them, but if we can't, we can at least direct them to where to go to get that next level of detail and build a more informed care plan for that patient.
Do you have an example or story you could share of this in action? And also, who's Dr. Tulo? Because you mentioned a Dr. Tulo. What's his role or her role?
So I can give you the example. Dr. Tulo is our ambulatory, one of our ambulatory leadership physician that he was heavily and still heavily involved in this initiative. Some of the examples, like give you an example of demonstration. Today we have once we have a patient on one of our ambulatory site, and if that patient was in other organization other than MediSys, we actually have what we call a yellow sheet or an Excel sheet, spreadsheet, that have some of the diagnosis for those patients from elsewhere. Now, our physician has to go through that pane on that Excel sheet or that yellow printed form and start to validate those diagnoses. then take them into the EMR and do what they need to do for that visit. So you can
perforated yellow paper coming out of that.
Exactly. Exactly. And you can think about this. I mean, a physician with everything happening today, they have to toggle between that piece of paper and the EMR system and try to figure out what's the right diagnosis and agree with those diagnoses from a prior visit for that patient from another physician. The integration that we thought about it, physician came loud and clear that, hey, this is too much. It's hard for us to still do paper. It's hard for us to toggle between two different systems. And that's where we worked on start the whole idea of the integration inside the EMR system with GT and his team from Healthfirst to bring it into one place, one human-centric system.
So the insights that sort of Healthfirst has to provide to the provider on sort of outside of MediSys engagements, what would be an example of one? Like you talked about this member, this patient's in your ambulatory setting, they came in to your setting, they've been elsewhere, doctor's holding a printout, looking at the EMR, but what are the insights now in this new process that you guys have created, for an example, that the doctor would see right away? Tell me a real life example of one.
So with that new integration that we build, all this information come directly to our EMR system.
Okay.
With a very nice application inside our EMR system where the physician can today actively on actual data, he can validate that diagnosis for those patients from elsewhere. So those are all diagnosis driven, and also that also will help doing the care gaps on the real time.
Okay, couple questions, follow-up questions. One, this is more than just a scan of the PDF. This is actually integration of the data and insights into the EMR.
Correct.
Great job. Okay.
That's right. Okay.
I'm sorry, go ahead, GT.
No, that's right. Yeah, and it's bi-directional integration. So when we serve up insights that require some form of action, we are capturing that action. Wherever we can, we are automating the implications back to the EHR platform, and we're capturing that feedback back to the health plan. So we know if, for instance, a prior diagnosis code that we put in front of a physician, like a physician, we might tell the physician that this patient has a prior diagnosis code of depression. The physician may say that is no longer relevant. That's valuable information for us to have, that the condition is no longer present in that patient. So we clear it up with regard to managing the diagnosis codes and the problem list within the EHR without the provider having to do anything but click a couple of buttons. And then we feed that back to to the Healthfirst team so that we understand not to chase that condition anymore and to propagate that information to other parts of the healthcare system that might interact with that same patient.
So it's one source of truth for that individual, neat and tidy. Help me understand, and this may be a little of a novice question, but I just want to make sure my audience has full understanding. So, we're all familiar with the big HIEs and certainly the Commonwealth and care quality networks that allow EMRs to sit on these networks and talk to each other to some extent. How is what you're doing different from that?
So I have my point of view on that. I think that I think there is value in those very large data sets being available to other clinicians. And, New York State has its own health information exchange that has added significant value to the healthcare ecosystem. But what we've learned through some of this interaction with Sami and his team and the physician leadership at MediSys and other institutions is that frequently what they want is very specific information, very targeted information served up at very specific points within their workflow. They don't want to see a big document. They want to see the 3 diagnosis codes that need to be considered for this patient. They want to see the 4 gaps in care that are open and the 3 gaps in care that have been closed. They want to see the current medication adherence data for those members. So what we give is fresh data, but much more targeted, specific information that is useful to the clinician at that point in their workflow.
That's great. Anything to add there, Sami?
Yeah, absolutely. I mean, in the past, before this integration, for us to get this information, as I mentioned, was all spreadsheet, or maybe we even have to go to a claim file to try to pull some of this historical data on our patients. Now we don't have to. I mean, they're all coming fully integrated in our EMR system. And again, it's just a few clicks and they merge into the record in our system. There's no need to go to an external source to pull this information from.
Okay. Last question, and I do want to move to impact, but I want to make sure everyone has a clear picture in their mind's eye on how this works. So can you quickly, step by step, so the information, someone goes to an out-of-network ER, other ambulatory setting, and how are you collecting that data? And is it MediSys or Healthfirst that does that? It must be Healthfirst because they're collecting the claims. And then that data gets sent in a digital format into your new system that integrates into MediSys's EMR, which is the same view that Healthfirst has, same EMR they're looking into.
So Healthfirst as a plan doesn't have a medical record platform. So, but you're right, Healthfirst is the aggregator of all of this information. And what we do is we create these FHIR API endpoints. So we're very committed to FHIR as a language of interoperability. We create these FHIR API endpoints and we wrap UIs around them, user interfaces around them, if that is desired in the delivery system that we're working with. So we can either give you an endpoint to consume the data and you can put it into a user interface that you already have, or we can give you a little user interface that you can snap, in this case, snap right into Epic. The physicians don't ever see it as anything other than Epic, but that's the nature of the integration. It's so that you're always getting the freshest data. It's an API endpoint that gets invoked anytime a patient, anytime a physician at MediSys opens up a patient profile within Epic, it pings our platform and we serve up this API endpoint to give them fresh data.
Okay, so for a physician, it's basically painless.
They don't even think, they are not leaving Epic. It's right in their workflow.
Yeah, it's very seamless, Eric. They don't even know where is this coming from, and if you want to like the transparency of this data, it looks and feels just like our EMR system Epic. It lives inside and it pulls data fresh all the time.
Okay, so it's a great transition point. So Sami, let's talk about impact to the provider, and you might have just answered it, but like, what is the overall impact to the providers at MediSys right now? Like, tell me a little bit about their job, their life, what this does potentially for burnout, certainly their ability to practice great medicine.
Oh, absolutely. I mean, they love it. Let's put it this way. For the physician committee and for the group of physicians that we worked with to implement and to build that integration, they devote the time because they know the end results. Hopefully it's something that they're going to like. And they do like it today after we went live. They use it. They understand they don't have to toggle between that and spreadsheet and the what I call, quote unquote, the yellow paper form that they have to fill in the information. And any click that we can save for our provider, any additional click or any additional workflow or toggling between different systems, it's important for their well-being and their burnout. Remember that we give them more time and less frustration to do a better patient care. And that's what matters to our provider at the end of the day.
Have you done anything formal around surveying your providers? I'm sure nurses and advanced providers are involved in this too, is my guess. Have you done anything around NPS? Do you have any kind of data to suggest that, wow, this is just changing our culture, or at least not yet?
So we didn't get to a formal survey per se, but we do have a monthly meeting with our care provider to go through any point or any changes that they want to see in the system. We do also look at productivity and how the tools are used and if they need more alpha support moving forward. But we did not have a formal survey yet.
Okay. And GT, like, how is this changing the lives of the human beings that are being taken care of? How is this impacting the member?
Yeah, I mean, the ultimate vision, if you look at Healthfirst, our vision is to make healthcare easier and more equitable. And so, if we're going to achieve that objective, we have to redefine the way the healthcare ecosystem collaborates. The B2B ecosystem in healthcare is rather outdated. And so when these solutions are delivered, the net effect is that physicians have better information, so they are delivering better care. And the physician and the entire healthcare ecosystem can more effectively collaborate to get better outcomes for the consumer. So I'll give you another example of capabilities we're introducing in this platform. We're doing closed loop referrals to social service agencies. So now I can put that in clinician workflow. They don't have to go someplace else. I can put that in clinician workflows. So if they come across a social need, we can make it very easy to refer them to a curated network of social service agencies, and make sure that they're getting access to the services they might need that ultimately will address their health in the short term and long term.
You mentioned equity. Is there an example you could share about how this collaboration is impacting folks that may be historically underrepresented?
Yeah, I mean, we're doing some really interesting work around, if you think about, so Healthfirst is a pioneer in value-based healthcare. If you think about value-based healthcare, it's defined as kind of this financial model, but it's really a business model that fosters collaboration. If you think about what really makes value-based healthcare work, it's the small networks of providers, social service agencies, physicians, hospitals that come together to meet the needs of a specific population. So we've done some work with some high-risk maternity patients where we are knitting together the delivery system in ways that will allow doulas, OBGYNs, hospitals that do the delivery, but also knit in the social service agency, housing support, legal support, childcare, nutrition, behavioral health, professional behavioral health, and social service type behavioral health needs of those members. And so it's these small networks that come together in hyper-local ways to meet the unique needs of these consumers. And the vision of this platform is to digitally enable those networks of providers to come together to achieve that objective.
How are you connecting, let's say, a CBO to all of this? Like, how does it benefit a CBO so that they could benefit, that expecting mother?
I mean, there's a lot going on in this space, the CBO space, with the 1115 waivers that are being contemplated. But we have curated, we have in New York, we have a curated network of social service agencies that is the Healthfirst network of social service agencies. And we, using this platform, the social service agencies can manage their entire panel of patients in this platform. Or if they already have a platform that they use to manage all of their clients or patients, we will integrate with that platform and send referrals into their platform for patient management. So what the social service agencies, what the CBO have, is a convenient way to receive these referrals. And what value-based design and the concept of the 1115 waiver is all about knitting that into the broader healthcare ecosystem. And when we get this right, everybody understands the structure of the programming of the CBO. What assessments are they doing? What's their treatment protocol, their engagement protocol? How are they measuring success? And if they take those actions, they get paid for delivering that care. So to a CBO, it makes it easier for them to fulfill their mission. But also part of the vision is that we understand which social services do have that financial impact on healthcare outcomes, clinical correlated to clinical and financial outcomes, not just financial. But also what happens for the CBOs is now they've got a more steady stream of funding. As long as they deliver these services to these members in a compliant and effective way and are getting the outcomes that are agreed upon, then they've got a much more stable flow of income. They get paid for delivering those services. So that's the vision that we're after. And we've got a footprint in New York where we're achieving this objective. We've got a footprint in Connecticut and Massachusetts where we're achieving this objective as well.
So all of this must tie into an impact of the Healthfirst business and the MediSys business too. So let's start with Healthfirst. Like, how is this helping with star ratings? Is it helping with measurable reductions in total cost of care? Like, how is it impacting your business?
Absolutely. So, in a Medicare Advantage business, it is directly impacting our HEDIS measures that drives stars and quality. It is also helping us make sure that we are getting appropriate risk-adjusted revenue for the complexity of the patients that we serve. So these are measurable impacts. And if you want like an example, recently, we came across a cohort of members who were struggling with the services associated with some disabilities that our members are experiencing. And so we came upon a program where there is a peer mentoring program available for these members. And so within a couple of days, we were able to configure that platform to be part of our referral infrastructure, get those members connected. And within 2 months, we've had 1,500 members connected through that service. And they've got a peer with similar characteristics helping them navigate and get better care from the healthcare system, get better outcomes, and just live a better life.
I love that. That's super powerful. What about on the MediSys side, Sami? How is it impacting your end of the business?
So definitely it's impacting. First, we'll start with the provider, where they now have everything in one place. So it's making their care for the patient much better than before. In terms of looking at the star rating, closing the care gap, taking care of the high-risk patient, of course, there is a huge improvement on our Healthfirst population by using this integration.
Great, similar things.
And the thing I would add too is with the value-based business model, the economics associated with the improvement all goes back to MediSys, for the population that they take risk on. So they get better flow of money to continue to pursue their important mission in the communities that they serve.
Yeah, I like that a lot. Could you guys, for context, like how long has this partnership in its present form been up and running, and rocking and rolling?
Let's see, we went live just over a year ago, and we were probably working on it for 9 months before that. But it actually dates back, Sami, I'm sure you remember this. Yeah. Remember the hackathon we did 2.5 years ago, just kind of experimenting with, how would we take these things that we deliver with spreadsheets? We did a Friday, Sami and I jointly hosted a hackathon on a Friday, summer Friday, must be 2.5 years ago, where we explored this art of the possibility. How do you take the spreadsheet data and put it in physician workflows? And his team did it in that day. It wasn't production ready, but it was eye-opening for anybody it was one of the most energizing days in my career. It was fantastic. And I think that felt like an inflection point to me in the conversations we were having internally.
That's great. That's a great story. Let's actually, one of my kind of favorite questions to ask, like there's a lot of hospital and health plan leaders, maybe some CIOs listening right now. Let's help them, create a blueprint for this provider-centric approach to collaboration. Can we just outline, and Sami, I'll start with you, what you think the blueprint is, like the 3 to 5 key pillars here that has allowed you to develop this partnership and continue to make it work and advance it?
Absolutely. Most important is listening to your provider, your user at the end of the day, right? What are the pain points? This is how we started the whole thing. It was an idea, and then once we start to listen, dig into it, we start to see, hey, can we make it happen through technology, yes or no? We wanted also to, for our provider, we wanted to have a single place for the data. We wanted to have an easy application to use for them with a very, very, very little, maybe almost close to no training on how to get them to use these tools, since we designed it within the same EMR system that feels and look alike the EMR system. So that was the key driver here, engage our user in the design and every phase as we go in the project.
Okay, so I heard two things there. Correct me if I'm wrong. And GT, I'm going to switch to you in a moment. Provider participation, and you don't mean like the executives, the CMOs,
Yeah.
the people actually, the doctors and the nurses and the other advanced providers doing the work. So provider participation, number one. And two, a single place for the data with an intuitive, my words, not yours, user interface.
You got that correct. Yep.
Okay, I didn't miss anything there. Those two things you're putting into the blueprint. We're authoring a pretend blueprint.
And ease of use. Very important that you don't deliver complicated product, right? It's easy, simple enough to use. What I call self-evident application.
Self-evident application. That's what I meant by intuitive user interface.
Okay.
Are you saying something different? Just to make sure.
It's similar, but remember, it's provider always short on time to learn any new system or any new way of doing things. So while we're designing, we were thinking, hey, how can we make it close to what they do today?
Okay, and repeat that for me again. Self-evident
application.
application. Okay, great. What are we going to add, GT, to our best-selling blueprint?
Well, I think we all as an industry need to be committed to making healthcare easier for consumers. I don't think that's a new theory, but I do think that one of the reasons we love working with Sami is that if we're going to make healthcare easier for consumers, we got to make it easier for providers. There are too many providers or clinicians who do their job in spite of the technology they're forced to use, not enabled by some delightful technology experience, right? So if Sami and his peers are going to lead this journey within their institutions, the rest of us have to support it. And I think the whole industry is beginning to go through this wave of digital disruption, modern digital collaboration. And I think what that requires is that we all think differently about collaborating. Like in industries that have been disrupted, you find leaner participants who are really focused on doing the things they do very well, and the other things they are delivered through these platform type capabilities. So everybody in healthcare has to figure out what they do uniquely well and focus on continuing to do that uniquely well. And then the other thing everybody in healthcare has to do is collaborate more efficiently and more effectively, including collaborating with your competitors. Digital disruption breeds a lot of this kind of co-opetition dynamic, and I think we have to embrace that. Okay,
so what I heard there that you added is obviously focus on consumer and ease of use, just like we focus on the provider and their participation. And then I don't know how to articulate this, but just so our audience has a clear takeaway here from you, it's almost like as your organization, do your job, stay in your lane. Sort of the Bill Belichick mantra: just do your job, stay in your lane, and then if some overarching culture or one leader fosters that collaboration, as long as people are doing their job and what they're good at, and that collaboration is fostered effectively, great things could happen.
Yeah, it is. Stay in your lane is a little bit. I don't know. It's perhaps stronger than the language I was intending to use, Eric, but it's not inconsistent. I think the thing is for everybody to behave like we're part of something bigger. At the end of the day, we're all part of this healthcare ecosystem that is intended to address the healthcare needs of us and our fellow citizens. And the front line of that is the clinician. So let's enable the clinicians, but let's this idea of let's all behave like we're part of something bigger and connect it back to that mission, if that makes sense, the more helpful.
It totally makes sense. At the risk of going off topic, I was recently, my family is a big fan of the show Survivor. They're not a sponsor of this episode, but I'm going to plug it anyway. And I was listening to a podcast with the showrunner and host, people may know, is Jeff Probst, and he was talking about how the filming and production of that show, there's everyone who does the little things, whether it be manning the drone cameras versus designing artwork versus figuring out how a challenge is going to be designed. Everyone is so good at their jobs and they focus on their jobs, but they all have the same mission every morning when they wake up, and that's to make the show great. And so they're all doing their job. They're all, I'll use my term, staying in the lane, but they're all collaborating to make the show great and put on a great show. It sounds like a similar sort of culture that you're trying.
Absolutely. Yeah.
Tell me a little bit, and Sami, I'll start with you. To me, when you have a bright spot like the one that we're talking about today, and this great partnership that's been forged between MediSys Health Network and Healthfirst, it's all about how do you make that bright spot scalable across the country. And so tell me a little bit, Sami, about, how you're trying to share the wealth, how you're trying to get this message out beyond coming on this show around this partnership.
So it's always, let me start by just thinking from healthcare giver and a payer, like Healthfirst. We discuss things internally. We look at all the information that we have, and then a very important partner to any healthcare giver is the payer at the end of the day. So this integration and all this talk about the integration between the healthcare giver and the payer is very important. So what a lot of ways for me, to share the wealth with any other organization. We talk about it in the different user conference. We talk about it in different meetings and different sessions with different organizations. And sharing this wealth is important because at the end of the day, we have the same pain point that any other organization have when they deal with patient coming from outside of the network. I get to the point where I'm willing to share any of those integration with anyone at any given point if they just ask for it and provide it to them. I don't know if I answered the question or not, Eric.
Well, I think you have to. So I think there's some. The answer is you get partial credit. So tell me a little bit about, and maybe GT, you could jump in from your perspective, like how you're taking this wonderful partnership and bringing it to the rest of the country, and this concept of bringing it to the rest of the country. Tell me.
Yeah, I would say we are still disproportionately focused on advancing the needs of the members of Healthfirst in our market. We serve 1.9 million New Yorkers. 1 in 5 New Yorkers actually get their health insurance from Healthfirst. And so, Sami's and his team are very generous as a design leader on this. Now we're looking to implement this with other hospitals, other primary care practices. We'll be integrated with 150 community pharmacies, putting 6 insights into their workflows in June to help them in their point of care system as well, so that they can see insights that they historically have had to download spreadsheets in order to get. And so we're really spreading the message within Healthfirst, although we do have a very significant footprint in Connecticut and Massachusetts as well. And we're starting to talk to other like-minded, value-based, provider-sponsored, population health committed health plans around the country as well.
And how do you intend on doing that? How do you intend on getting to other health plans around the country?
Well, we recently were awarded a best-in-class award for payer-provider collaboration, so we had the opportunity to tell our story there. There are various, as Sami alluded to, various forums where like-minded plans come together, whether it be HLTH or other forums like that.
And Hyphen, maybe you want to mention Hyphen also, Eric.
Yeah, what's Hyphen?
So Hyphen is the entity through which we actually delivered this capability, Eric. So Hyphen is a wholly owned subsidiary operated at arm's length, but a separate company, a subsidiary of Healthfirst Management Services. And it's a payer agnostic platform with a very bold objective of redefining the way the healthcare ecosystem collaborates in service of value-based, provider-sponsored population health. And so we launched Hyphen because, as I mentioned earlier, value-based healthcare is really it's a financial model, but it's a model that uniquely fosters collaboration, right? And so, but we believe we've hit kind of the point of diminishing returns with our old ways of collaborating. So why do this through Hyphen and not directly with Healthfirst? Because providers like Sami and like the other providers in our network and part of our network, they each have a different starting point. They're each willing. They have different priorities, and they are interested in different capabilities to be delivered in a sequence that makes sense for them. And they're all willing to move on that journey, but none of them want a solution that only works for a single payer. So we're delivering all this stuff in a payer agnostic way because Sami doesn't want a solution that's only ever going to work for Healthfirst. So we put these insights into their workflows, but now other payers in our market could publish their insights into this platform. And when they do that, they'll show up in Sami's physicians' workflows as well. So that's a bit about Hyphen. And I'm always happy to share more.
Talk a little bit about how you guys are going to take this concept of collaboration.
I'm sorry. Yes, you're absolutely right.
And that's what hyphencare.com, right?
Hyphencare.com. That's correct.
YPHEN care.com. That's great. I love everything that's going on. The innovation that you guys are doing down there is down there. I'm in Boston. They're down in New York. It's terrific. So I appreciate you taking all this time to share all these wonderful stories, ideas, and approaches. I think it's worth. There are lessons worth telling around the industry. So I appreciate it. I'm happy to be part of the spreading of the wealth here. So thank you both for the time here. How can people find you?
I am the only GT Sweeney on LinkedIn. So please look me up on LinkedIn.
I think me too. I'm the only Sami Boshut on LinkedIn. So I'm available on LinkedIn as well. Those are GT, right, GT? So
Find them on LinkedIn. Again, guys, thanks for all the time.
Thank you, Eric. Yeah.
All this. We hope all of you listening can use the bright spots today, share today to inspire your thinking and enhance your company's just approach to improving healthcare for all of us. Take these ideas, clone them directly, look at Hyphen Care, or take some of the concepts of it, steal them, bring them into your organization. That's how we make healthcare better for everyone. And remember, this is your Bright Spots in Healthcare podcast. Thank you, everyone.